Hello and welcome back to The Upper Hand. I'm Parker, this is Dylan, and today we will be giving you the upper hand with all things related to Quervain's Tenosynovitis.
That sounds kind of complicated.
It does, but after today you will learn that it isn't complicated at all. We will break it down for you and tell you all that we know. Okay, before we get started, we have to ask for a quick favor. If you would go and like this video and subscribe to our channel so that we can continue to bring you content like this in the future, we'd very much appreciate it. Also, if you're a therapist, tell you what, comment below on your go-to treatment for this condition. So let's get started.
So we'll start by breaking the name down so that it makes a little more sense. So de Quervain's Tenosynovitis is named after a Swiss surgeon named Fritz de Quervain. I've heard it pronounced about 50 different ways, probably a lot of ways to pronounce it. He first identified this condition all the way back in 1895. So the second part of the name isn't as hard as it sounds if you just break it down. Tenosynovitis. Teno refers to the tendon. Syno, it refers to the sheath around the tendon, and then itis, of course, is an inflammation. So this is an inflammation of the tendon sheath. So what is a tendon sheath and what is its purpose?
So the easiest way for me to explain and understand a tendon and a tendon sheath is to think about a straw and a straw paper around it. So the straw is the tendon, except it isn't hollow, and the straw paper is the tendon sheath. The purpose of a tendon sheath is to allow the tendons to move smoothly and freely through the compartments as they are filled with a lubricating fluid.
So on the dorsum of the wrist, there are 6 dorsal compartments. Specifically, de Quervain's Tenosynovitis is a tenosynovitis of the first dorsal compartment, which it consists of the APL and the EPB, which is the abductor pollicis longus and the extensor pollicis brevis. So you'll notice the word pollicis in both those tendons, which tells you that this has something to do with the thumb. You can actually see and palpate this compartment. So Parker, if you'll demonstrate that, if you take your thumb and abduct and extend it at the same time, you'll be able to see the anatomical snuff box, which is a term that's used for that area of the hand. It's made up of the first and third dorsal compartments. The third dorsal compartment consists of just the extensor pollicis longus, or the EPL, but the first dorsal compartment is going to be located on the more radial-sided compartment.
So typically this occurs due to a cumulative trauma or a chronic overuse of the wrist or thumb. Notice I said typically because there are some cases of an acute trauma where someone could have taken a blow to that area causing some inflammation. So when you have inflammation of those tendon sheaths, they no longer glide well, which is going to cause pain anytime you put those tendons on a stretch or anytime you abduct or extend the thumb due to the APL and EPB tendons firing. So back to our straw and straw paper examples. So as you noticed, this straw paper, the straw glides real well initially, but if you were to take and kind of scrunch that up, which is kind of what's going on in there, it's a lot harder for that to glide in there, so that's going to make it a lot more painful.
So if you or someone you know seem to be maybe suffering from this condition, there's a test, a provocative test called the Finkelstein's test that you can use to test for this. It's performed like so. Parker will show you here. It's positive if the pain is worsened. What this is doing is placing the already angry tendons on even more of a stretch, which of course is going to hurt.
So now there's been some recent discrepancy in research that suggests that this is actually the Eckhoff's test and that it has been mistakenly placed in the literature as Finkelstein's test. Most people you ask, and in most hand therapy books or programs, you're going to see it listed as Finkelstein's test, so that's what we're going to stick with for now.
So say you've been diagnosed with Quervain's, now what? How are we going to get your wrist and thumb feeling better and back to pain-free? So we'll start with the most conservative treatments and progress all the way to a surgical option.
So remember the word itis, it is an inflammation. So the first thing that is going to be probably most obvious, you're wanting to rest the wrist and thumb. Stop doing the things that cause pain in that area. So any type of repetitive activities that either require the firing of those tendons or putting those tendons on a stretch is going to cause pain. Some examples of this would be someone that is constantly working with syringes, like having to come up and out to push that syringe again. New mothers often suffer from this condition as they are now picking up their child. Your wrists kind of start ordinarily deviated here and they're having to forcefully lift up with resisted radial deviation or firing of those tendons. Or picking up a milk jug would be another example as well.
So just telling yourself to rest your wrist and thumb is a lot easier said than done, of course. So you could also start resting this inflamed tissue by immobilizing it. And so the way you do that would be to wear a prefabricated or prefab or custom wrist and thumb immobilization splint. Now we see people coming all the time with a wrist immobilization splint that has the thumb free and they're able to move their thumb and they're like, it's just not getting any better. Well, guess what? It's probably not going to in that brace because you aren't immobilizing the main issue, which is the thumb. So we'll have a link in our description below that will show you a good prefab brace that is one of our favorites that we like to use.
So you're going to want to wear this splint at minimum while you're active, but possibly even at night. It just kind of depends on the person, if you're a still sleeper or if you move around a lot. But we never like immobilizing joints if it's not necessary. So do you think you would need to immobilize the IP joint of the thumb? No, because remember, the only extensor tendon that crosses the IP joint of the thumb is the EPL, or the extensor pollicis longus. And remember, this is the first dorsal compartment, which is the APL, which inserts on the first metacarpal, and the EPB, which inserts onto the proximal phalanx of the thumb. Therefore, neither cross the IP joint of the thumb. So if splinting like we were talking about, you will want to educate your patient on keeping the wrist and thumb loose and not allowing them to get stiff, as this is just going to cause more issues.
So since this is an inflammation issue, the patient will need to be taking some form of oral anti-inflammatory. Ice is another option that's been proven to reduce swelling and inflammation. However, we are also not opposed to using heat for pain control. Most of our patients prefer heat, and as long as you combine it with elevation, we don't see an increase in edema afterwards, that's okay. We do educate our patients to avoid soaking their hand in a hot bath or hot tub, because that would likely cause swelling due to it not being elevated. We also like to follow moist heat up with some type of retrograde massage, either with your hands or some type of instrument such as a Graston instrument. Lastly, a compression sleeve or edema glove will also help with both edema and pain control.
So iontophoresis would be another option for the swelling. That would be a step up from the oral anti-inflammatory. Also, if a patient came in to us for this condition conservatively, ultrasound or phonophoresis would be another option that we would consider. And if you're thinking to yourself, what is phonophoresis or how will ultrasound help with this, just remember to subscribe to this channel, as there will be future videos describing these modalities in depth, as well as many more modalities and many more topics.
So if all this conservative treatment options that Parker's been talking about fails and the pain's bad enough, then the patient will likely progress to surgery. And the surgery for this condition is known as a de Quervain's release. So what the surgeon is going to do is release the tendon sheath around the APL and the EPB, which is going to relieve the pressure off of the tendons and allow them to move more freely or normally again, eventually pain-free. So they'll start, they'll still have stability of those tendons due to the other surrounding structures and scar tissue that'll form, so that's usually not an issue.
So like carpal tunnel, the only thing they did in surgery was release something. So technically nothing was repaired, so there are really no post-op precautions. We like to make sure we allow time for the tissue to heal, though, in order to prevent aggravating that tissue or causing the patient increased pain. We typically start range of motion as soon as we get them in therapy, but just being sure to go within tolerance, at least for the first 2 to 3 weeks, and then we like to start strengthening at that time.
So just like Parker said, there are no real post-op precautions per se, but you can have some post-op complications, as there is a very sensitive nerve that runs very close to where the incision was made during surgery, and that's known as the superficial branch of the radial nerve. So hypersensitivity can occur after surgery, and if that's the case, then we'll want to start them on some sort of desensitization program for that area.
So just to review, post-op goals are going to be pain reduction as always, with heat or soft tissue massage or E-stim like IFC or interferential current or high volt galvanic stim. Reduce edema with ice if there's no stiffness, compression sleeve or an edema glove. Desensitize the scar and surrounding areas if needed. Regain any range of motion loss or maintain normal motion, although typically there isn't much stiffness after this surgery. Of course, we're going to regain the strength in the thumb and the wrist starting at about that 3-week mark, as long as we allow enough time for good tissue healing. Strengthening can include many things, but typically always putty for some grip and pinch, weighted wrist strengthening or resistive wrist strengthening with a TheraBand, And lastly, eventual return to work or regular daily activities. So if they are someone who does heavy lifting, we will definitely incorporate that into our treatment session.
So we hope we taught you guys something today, or maybe refreshed you on something that you already knew and needed refreshing on. So if you enjoyed this video, comment below and let us know, and please share it with a friend or a classmate. And as always, stay tuned for future videos so that you can have the upper hand. See you guys next time.
Hey guys, thank you so much for taking time out of your day to watch this video. We hope you learned something today and that this was helpful to you in some way.
So you know our goal for this channel, The Upper Hand, is to give you guys the upper hand as you seek to better understand conditions of the upper extremity and just all topics related to occupational therapy in general.
So please take a second out of your day, make sure you like this video and subscribe to this channel so that you can be sure that you're going to see all of our upcoming videos. Thank you guys so much, and we'll see you next time.
Hola, amigo.
Hello and welcome back to The Upper Hand. I'm Dylan.
Wow. That's pretty bad right there.